done with the adaptive, and then we're going to move on to the ventilator. Dyssynchronies. Dyssynchronies are scary. You know why? Because they happen almost 95% of the patient. They happen in front of our eyes. We don't give a damn about them unless the ventilator is screaming. Unless the ventilator is going, beep, 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 nobody pays attention. But they're in front of our eyes, and the ventilator is not beeping, so it's like, oh, okay, well, we're good. You know, I'll come and check in a couple of hours. Dyssynchrony is shown again to worsen ventilator time, worsen mortality. So it's something that we really, really need to pay attention to. So the classification is pretty easy, actually. Either triggers dyssynchronies, whether early, late, or false, or failed trigger. We'll go through this. Work shifting as like that patient I told you, like breathing so deep with this esophageal pressure. Or cycle, like how does the ventilator starts, how the breath, starts, how does it end? So cycle, again, normal, late entry, early or late, and expiration. So let's go to pictures because pictures make sense. So if you see that patient, again, airway pressure, flow, esophageal pressure, can you, well, there is a blue arrow, so I guess you can see this. The ventilator doesn't beep, doesn't tell you anything, what's going on. So what do you think it is? You got it correct. It's the patient trying to breathe, but then the ventilator is not giving him any breath. So that's missed effort. And imagine you are sitting there trying to breathe, and the ventilator is not giving you air. You know what delirium happens? Part like, we're talking about yesterday, because of these things. If you're trying to breathe and you can't, you will be delirious and you'll be agitated. And what do? We just we paralyze. Our treatment, that's the sad part. Our treatment for most of the dyssynchronies, you would hear that word, patients bucking the vent, increase sedation, still bucking the vent, increase the propofol, add Presidex, add fentanyl, just paralyze the patient. Then there's no dyssynchronies, but it's probably not the right thing to do. So we have to figure it out and treat. How about that? This patient, like the ventilator, all of a sudden is breathing 60, 70 times per minute. It's like, then you look at the patient, he's paralyzed or sedated. He can't be breathing 60. Yeah, that's probably false trigger. The ventilator is acting crazy. It's triggering sometimes the heart rate. Like the sensors now are so sensitive, and it's lying on his chest, and it's detecting the heart rate as triggering the vent, or there's some water or something like that. So we have to figure this out. How about this one? You can tell, like, new generation ventilators in the past, it used to take like 0.3, 0.4 seconds for the ventilator to understand, oh, the patient wants to breathe. Oh, okay, I'm going to give him a breath. New generation ventilators doesn't even take 0.05 seconds. Very, very quick. But you can see here, the patient wanted to breathe, but then wait for like 0.8 or 1 second. And the ventilator is like, oh, you want to breathe? Okay, I'm going to give you a breath. Again, very difficult. Try it yourself. I was like, very hard. We have to detect this. This is something called, now it's the fancy name, that the same patient that I showed you, reverse trigger, meaning the breath started here. It's not the patient didn't start the breath. The ventilator started the breath, and after like say 0.5 seconds or something, the ventilator is like, ooh, I'm gonna breathe. Oh, and that's what happened to the pressure. You can see it went crazy. So this is called reverse trigger. They used to call it early trigger. I'm not gonna go through the ways of like treating them, but that's very important. Okay, this is again, you would see this all the time. It's like at the end of the pressure, there is a shark fin like this. You'd see it all the time. And that's early cycle, meaning what? Meaning that the ventilator here started the breath and went into exhalation, right? So if you don't have, and this is the patient, it went to exhalation, but the patient's still inhaling, right? So they're fighting each other. So this is called early cycle. Hard to detect really if you don't have an esophageal balloon. To be honest with you, most of them are hard to detect without an esophageal balloon. That's why, and the engineers of the ventilators knew that, again, clinicians, we struggle with it or suck with it. So they have now algorithms to try to detect it, automatically adjust the time and the cycle and whatever in the trigger to make it like a little bit better. I don't know if they work or not, but this is the other way, the delayed cycle. The ventilator started the breath and keeps going, almost inverse ratio, but the patient stopped. So if your ideal thing is to get the ventilator to the patient brain, have them both the neural time and the ventilator time all in the same time. It almost never happens. Work shifting is meaning with the patients doing so much work, as I showed you before here. This is actually a very nice card. If you don't know about it, it's free to download from Hamilton. The terms might have changed a little bit, but the same concept, like delayed triggering and effective effort, flow asynchrony, which we call work shifting these days, double triggering, which we call it now reverse trigger. But to explain to you how do you detect them and different ways, what's the cause and auto peep and weakness and all the stuff, and how to correct it. With this, I'm going to stop and we're going to get the ventilator and play with the adaptive modes just to show it to you in real time. And